Someone is in a hot air balloon and they realize that they're lost. So they call down to someone on the ground. Hey, I don't know where I am. Can you help me? And the person on the ground responds, you're in a hot air balloon about 10 meters off the ground. Your coordinates are around 52 degrees north and 4.5 degrees east. The balloonist says, you're an engineer, right? Because everything you said was correct, but useless. The person on the ground shouts back up, you're a manager, right? Because you don't know where you are, I gave you the information you wanted, and somehow it's all my fault.
Targeting neural communication to restore function, Medtronic sacral neuromodulation for the treatment of overactive bladder, mechanism of action. Overactive bladder, or OAB, is a urologic condition defined by urinary urgency with or without incontinence, urinary frequency, and/or nocturia. OAB affects about 37.4 million adults in the United States. Neural pathways in the brain, spinal cord, and peripheral nerves together regulate urine storage and elimination through coordination of the bladder, urethra, and pelvic floor muscles. During bladder filling, sensory or afferent signals convey information on bladder fullness, in part via the sacral nerves. The signal travels up the spinal cord to the brain. In response to the full sensation and at a socially appropriate moment, the descending motor or efferent brain pathways, which are under voluntary control, are activated by conscious thought. This causes the urethra and pelvic floor to relax and the bladder detrusor to contract, resulting in voluntary urine release. Dysfunction of the sensory and motor pathways alters the checks and balances that are critical to voluntary bladder control. In OAB patients, brain activity has shown abnormal responses in areas of the brain believed to be important in recognizing urge and frequency, and decreased activity in areas believed to be crucial to voluntary bladder control. Normal bladder functioning can be restored by influencing the sacral nerves, which convey a portion of the signals between the bladder, pelvic floor, and the brain. Medtronic sacral neuromodulation delivers electrical stimulation to a sacral nerve via an implanted neurostimulator. The neurostimulator provides an electrical charge to an area near the sacral nerve, resulting in altered neural activity. This stimulation likely depolarizes the nerve, causing an action potential that propagates impulses along the axon as if the neuron naturally fired an action potential. As a result, it is thought that abnormal sensory input from the bladder is modulated. OAB patients with sacral neuromodulation exhibit patterns of brain activation similar to that of patients with normal function when compared with OAB patients without sacral neuromodulation. These effects are observed in areas of the brain involving sensation, awareness, urge, and timing of urination. This suggests that sacral neuromodulation patients experience normalized sensory signaling to the control centers of the brain, while motor pathways are uninhibited so as not to suppress voluntary voiding. Unlike other therapies that target the bladder, bladder regulation via sacral neuromodulation occurs without physically influencing the bladder or sphincter muscles. Medtronic sacral neuromodulation with the InterStim system is a safe and minimally invasive treatment option for refractory OAB patients that provides continuous control through effective long-term therapy delivery.
This animation presents a full implant procedure using the InterStim SureScan MRI lead and rechargeable neurostimulator. The full implant is performed following a successful basic evaluation. Detailed procedural instructions are provided in the product technical manuals and must be reviewed prior to use. Position the patient on the table and administer sedation. Prep for sterile surgery by swabbing the lower back, sacral region, and buttocks with an antiseptic. Drape the patient to allow for observation of the pelvic floor and great toe motor responses. Ensure a clear view over the buttock and perineal area. After the proximal end of the test stimulation cable is handed off the prepped field, attach the black pin end to the ground pad and adhere the ground pad to the patient. Plug the adapter end of the test stimulation cable into the external neurostimulator, also referred to as the ENS. Once the test stimulation cable is connected, pair the programmer with the ENS. If connections are not secure, the Cable Not Attached notification screen will appear. S3 is the target foramen. To identify sacral landmarks, use AP fluoroscopy to identify and mark the medial edges of the foramina. Then, using lateral fluoroscopy, identify and mark the appropriate needle entry point, which is cephalad and parallel to the S3 bone fusion seam. Inject a local anesthetic to numb the skin near the entry point of the foramen needle. Insert the foramen needle. The needle tip should be inserted to a depth at or just below the anterior surface of the sacrum. To confirm desired needle placement, connect the test stimulation cable to the non-insulated portion of the foramen needle. Increase the stimulation as directed by the physician. Observe for motor and sensory responses. Responses should be observed at low amplitude levels, preferably 2 milliamps or less. The desired S3 motor response in the pelvic floor is a bellows, a pulling inward or deepening of the inner gluteal fold. The desired foot response for S3 is a plantar flexion of the great toe and occasionally other toes. For women, the S3 sensory response is often vaginal sensation extending to the perineum and rectum. In men, the common S3 sensory response is sensation in the base of the penis, extending to the scrotum and rectum. To insert the lead introducer, first remove the foramen needle stylet and replace it with the directional guide. Then gently remove the foramen needle, being careful to stabilize the directional guide so it is not removed. Make a small skin incision at the exit site of the directional guide. Place the lead introducer sheath and dilator over the directional guide and advance it to the foramen so the radiopaque marker is no deeper than halfway through the foramen. Placing the lead introducer too deep could create a false path, which will not allow the lead to closely track the nerve. Twist the hub of the dilator to unlock it from the introducer sheath. Remove the directional guide and dilator, leaving the introducer sheath in place. The InterStim SureScan MRI lead has 4 electrodes, numbered 0, 1, 2, and 3. The deepest and most distal electrode is 0. The lead comes preloaded with the mini hook guide and bent tip stylet. The mini hook guide allows for precise electrode testing, and the bent tip stylet allows the lead to better track the natural path of the nerve. Insert the tined lead into the introducer sheath and, using fluoroscopy, advance the lead to the appropriate testing depth, with electrodes 2 and 3 straddling the anterior surface of the sacrum. The distal lead tip should be oriented medial to lateral and in a cephalocaudal direction. To confirm the ideal lead placement, ensure all 4 electrodes are distal to the introducer sheath and test for responses on all 4 electrodes. Once appropriate responses are obtained, the tines can be deployed. To deploy the tines using fluoroscopy, hold the lead in place and carefully withdraw the introducer sheath, ensuring that electrode number 3 is no deeper than just below the anterior surface of the sacrum. The tines will deploy as the sheath is removed. Detach and remove the mini hook guide and bent tip stylet from the lead. Test all 4 electrodes again to confirm previous responses after deployment. Obtain final lateral and AP images. Identify where the neurostimulator will be placed and inject local anesthetic at the skin and surrounding tissue. The pocket site should be located below the iliac crest and lateral to the edge of the sacrum. Make an incision just large enough to accommodate the implanted components. Create a pocket using blunt dissection. It should be no deeper than 1 inch for the 97-810 InterStim micro neurostimulator to ensure proper telemetry with the communicator and recharge with the recharger. To avoid infection, it is recommended that the neurostimulator implant site be irrigated with antibiotic solution and sterile water. Do not use saline. Using the tunneling tool loaded with the passing tube, tunnel from the lead incision to the pocket incision, taking care to avoid damage to the lead. Make sure the tunneling tool passes through the fat and is not too superficial. Unscrew the tip and remove the tunneling tool, leaving the tube in place. Carefully pass the lead through the tube until it emerges at the pocket site. Remove the tube at the pocket site. Dry the contact points on the lead and fully insert the lead into the header of the neurostimulator until you meet resistance. If the lead cannot be advanced, use the torque wrench to back the set screw out slightly. Do not remove the set screw. Use the torque wrench to tighten the set screw on the header until you hear a click. After confirming proper fit, insert the neurostimulator into the pocket with the Medtronic logo side facing outward, away from the muscle, and wrap any excess lead around the neurostimulator. Irrigate with antibiotic solution and sterile water. Do not use saline. With the neurostimulator in the pocket, use the smart programmer and communicator to check impedance and confirm that all InterStim system components are correctly connected and tightened. Ensure hemostasis and close the pocket with subcutaneous and skin closure, taking care to leave no dead spaces. Secure the incision and exit site with dressing. Use the smart programmer and communicator to program the neurostimulator and document the settings. Provide the patient information on post-op care, follow-up guidelines, and instructions on how to use their smart programmer, communicator, and recharger. It is strongly recommended that instructions be provided to patients preoperatively, prior to anesthesia being administered for memory retention purposes, and to help. This animation presents the removal of an InterStim SureScan MRI lead and connected components following an inconclusive advanced evaluation. Detailed procedural instructions are provided in the product technical manuals and must be reviewed prior to use. Prior to positioning the patient on the table, the external neurostimulator stimulation can be turned off using the clinician app, the patient app, or by disconnecting the ENS from the percutaneous extension. If you would like to generate a usage graph or a report, use the clinician app on the programmer and select End Evaluation. You can also turn stimulation off using the patient app. Slide the arrow to the off position. Additionally, you can turn stimulation off by removing the ENS from the percutaneous extension. Position the patient on the table and administer sedation. Prep for sterile surgery by swabbing the lower back, presacral region, and buttocks with an antiseptic. Drape the patient to allow for the observation of the sacral area to include the previous lead introducer site and pocket site. Local anesthetic is injected at the skin and surrounding tissue of the lead introducer and pocket sites. Open the pocket site using normal surgical procedure and carefully remove the connected components from the subcutaneous pocket. Using a torque wrench, loosen the connection set screw by turning counterclockwise approximately 1 turn. Gently retract the lead from the connector block. Cut the percutaneous extension below the protective plastic sheath. Discard the connector. The remainder of the percutaneous extension exiting through the contralateral exit site can be removed and discarded. Make a small incision at the lead introducer site above the sacral foramen and expose the lead. From the lead introducer site, gently grasp the lead and pull so the proximal end of the lead travels from the connection pocket site through the subcutaneous tissue. Continue pulling until the proximal end of the lead has been removed from the body. To remove the tined portion of the lead, use gentle traction and pull the lead in a straight, not oblique line. Remove the entire lead. Use only gentle traction. More than gentle traction can cause lead breakage, which can result in unretrieved device fragments. Ensure hemostasis and close the lead introducer and pocket sites with subcutaneous and skin closure, taking care to leave no dead spaces. Secure the incision and exit site with dressing.
Sacral neuromodulation is a guideline-recommended therapy which helps to restore normal control of the bladder and bowel. A small implantable neurostimulator is connected to a lead that is placed adjacent to a sacral nerve root. The lead delivers electrical pulses which modulate the activity of the sacral nerve. For people with overactive bladder, non-obstructive urinary retention, or bowel incontinence, there's thought to be abnormal communication between the bladder and the brain. Sacral neuromodulation is thought to work through activation of somatic afferents in the sacral nerve, which modulates spinal and brain control of the bladder and bowel. By restoring normal communication between the brain and the bladder and bowel, sacral neuromodulation therapy can significantly improve a patient's quality of life. There are two methods available for delivering stimulation to the sacral nerve: constant current stimulation and voltage-controlled stimulation. With voltage-controlled stimulation, initial programming is performed so the stimulation activates the sacral nerve. As part of the natural healing process, the lead is encapsulated by fibrotic tissue, increasing electrode impedance, which results in less current being delivered to the sacral nerve. This results in less activation of the nerve and may be associated with loss of efficacy and the need for a patient to adjust their programming settings or come into the physician's office for reprogramming. However, more stable activation of the sacral nerve may be provided by constant current stimulation. Initial programming is performed so the stimulation activates the sacral nerve. As the lead is encapsulated by fibrotic tissue, impedance increases, yet the same current is delivered to the sacral nerve. This is expected to result in the same activation of the nerve, which may provide continued efficacy and comfort with less need for reprogramming. With thoughtful innovation and clinically proven results, the axonic system is improving treatment of overactive bladder, bowel incontinence, and urinary retention. Approved to last 15 years, the small implant delivers constant current stimulation, offering patients the opportunity for more consistent and fuss-free therapy.
Variations and complex course of the pudendal nerve and its three branches provide many opportunities for nerve entrapment, which can cause pain from the anus to the genitals. A variation is shown on the left and the right side of this pelvis model. On the left side is the result of our research, showing the three sacral roots forming two separate pudendal nerve trunks. The traditional view shown on the right side of this pelvic model has the three roots forming a single trunk. We put this model into the lithotomy position to demonstrate these nerves exiting from beneath the sacrotuberous and the sacrospinous ligaments. This is shown in a female model with an incision near the labia on the left side. This can be used for operating on the perineal and dorsal branches. The exits from Alcock's canal can be variable. Our research has shown that on the left side we must consider two separate exits. This is now shown in a male overlay with the dorsal branch being more anterior. The model can be rotated to view the nerves from many different positions. Now, with the patient presumed on their belly in the prone position, an incision can be imagined in the ischiorectal fossa that gives exposure to the rectal branches.
Here is the coccyx, and the nerves can traverse outside, somewhat compression coming this way, and then there's the perineal branch that comes into the perineal area. Then there's the inferior rectal branch that goes along the rectal opening, and then there's the dorsal branch that comes in underneath from this portion here, and then will either give maybe potential clitoral pain or external vulvar pain, and for a man, penile shaft or penile pain in general. So these are ligaments that crisscross each other. So this is sacrospinous, this one's sacrotuberous. So where the ligaments will intersect can be areas of potential compression.